present in this till the end of the lecture. We are really delighted to have Dr. Professor Sunder Mudaliar, who is the Professor of Endocrinology and Metabolism from UCSD. And he is going to be President of the Endocrine Society of India also for this meeting, and they would take over and conduct the proceedings. Please.
Thank you, Dr. Narasimhan, for having brought us here to be with a personal friend. We all are aware that there have been issues regarding the relationship of macrovascular disease, renal disease with diabetes. We thought that we knew the answers and we could solve them through glucose, but trial after trial showed that while the renal complications could be handled to some extent, both in type 1 and type 2 macrovascular diseases somehow evaded the kind of success stories that we were wanting to look at. It is pretty clear that we are not going to reach anywhere with glycemic control alone, because that's a very small contributor to the whole puzzle that is macrovascular disease. Even if we control the disease early, as happened in UKPDS, you had results only 10 to 15 years thereafter. Nobody imagined that therapies which have so far been directed against controlling or containing the glucose losses in the urine would fail, and a therapy that makes one excrete glucose to the urine would succeed by pathways which are yet being dissected and delineated. We now know that there are molecules which can address this very quickly and very predictably, both in the renal and in the cardiac arena. And it appears that, to borrow phrases from very senior people, that the organs used to talk to each other, the specialists are talking to each other just now. There is a story that the excess ectopic fat contributes to dysmetabolism in the liver, in the pancreas, maybe fat deposition around the heart. And all these cardio-reno-metabolic features are not complications of diabetes, but they are common features of diabetes. And if you have one drug which can address some of these, then you are likely to see the kind of benefits that we are seeing, not just in glycemic control, but in patients with ASCVD, heart failure, liver diseases, and many, many more. Dr. Sunder is an original worker in this field, and it's a proud privilege to have him here with us. On one-to-one basis, we can discuss with him, and he's going to tell us some of the mechanisms that might be core factors in resolution of this process, because SGLT2 inhibitors may be just a direction. There may be many other molecules which might mediate the effects for better cardiac, renal, and maybe hepatic health. So without prolonging my monologue any further, and before Sunder says the lecture has been completed by a lesser mortal like me, I would invite him to the dais to give his talk, and please feel free to ask him questions. He is a basic scientist, an excellent clinician, and overall a person with a lot of humor. Over to you, Sunder.
This, you have to switch it on, then it comes on. I didn't switch it on. That's over there. Thank you for the kind introduction, Dr. Sethi. And I was just checking my slides to make sure I opened the right presentation, because many times I've gone and it's a completely different presentation. I don't know if you know this is many years ago, S.M. Krishna was Foreign Minister of India. And they gave an annual speech in September at the United Nations. Everybody's speeches is loaded up over there and everything. So Mr. Krishna got up and he started his speech. After 2 minutes, people realized he's reading the speech of the Portuguese farmer. And he didn't know. These are these ministers. He's reading, and then he figured out he's not reading his own speech. So the topic of my thing is these molecules. I have learned more about diabetes. I've worked with these molecules for about 10, 12 years. It has taken me deeper into the understanding of diabetes than I ever thought I knew before that. First of all, my conflict of interest disclosures are up there. I do speak for AstraZeneca, but it's got nothing to do with it. I get research support. In case you guys, if you don't know, the GRADE study is an NIH study looking to see after metformin, which is the next best drug. Nobody knows. So we studied with metformin, glimepiride, sitagliptin, liraglutide, and glargine itself. And of course, the big question is, why was there not an SGLT2 inhibitor? At the time we started our study in 2013, there was no SGLT2 inhibitor approved. The DCCT EDIC study, as you know, is the first study before UKPDS was there, but it is the first type 1 diabetes study. And it is the first study which said that if you treat patients with diabetes and bring their sugar down, you reduce microvascular complications. I still remember when I went to the United States, there was this patient, blood sugars are running 250, 300, A1C was high, and I said, I want to put him on insulin. So my attending told me, why? I said, the sugars are running 300. He said, so what? Show me the evidence that if you bring the sugar down, anything happens. And then this study, it's still going on. We're in the 33rd year of the study. That's the DCCT. And of course, the diabetes prevention program is in its 25th year. We have the largest cohort of people pre-diabetes progressing. So what am I going to talk about? I will describe how cardiovascular disease and diabetes is more than atherosclerotic CVD. That's how classical MACE, that's what we say, major adverse cardiovascular events. I will make the point that heart failure is a very important component of vascular disease and diabetes. Review a little bit the lessons learned from the CVOTs or the cardiovascular outcome trials. And I'll make the point, these are the two main drugs, the GLP-1 receptor agonists, they act on atherosclerotic cardiovascular disease, the so-called pipe. Whereas SGLT2 inhibitors don't have much effects on the pipe, maybe because of their glucose, lipid, blood pressure, but they work on the pump, which is the myocardium. And if there are two concepts I want to introduce, one is fuel energetics in the development of heart failure. If you look it up, I coined the term myself. It did not exist. I put fuel energetics, and now if it's come into the literature. I want to also describe the concept of therapeutic ketosis in the treatment of heart failure. This is a cardiology-oriented talk. You may have seen this slide many times. This is the famous differenzo ominous octave. There are all these organs which contribute to hyperglycemia, the kidney, the pancreas, the liver, the muscle, all kinds of defects. That's the bad news. The good news is we have drugs for all of them. And the latest class is the SGLT2 inhibitors. Two important differences between them and the other drugs is, one is these drugs do not need insulin. They act in the absence of insulin. Of course, some of these drugs do also act without insulin. Secondly, these are the only drugs which don't keep the glucose in the body. Whether you use incretins, GLP-1, insulin, that glucose is retained in the body. This dumps the glucose, as it were, outside. Of course, we have insulin, and we use all these drugs to lower blood glucose. But as Dr. Sethi alluded to, tight glucose control improves microvascular complications, but really does not have any definite effect on cardiovascular disease that we know of. Now, we've all used metformin for 60 plus years. Does metformin have any cardiovascular benefits? I see some heads going this way, this way. except in the UK PDS, and the p-value for that was 0.052. We're actually doing a study with 4,000 patients in the United States. The problem is metformin is standard of care, so we can't deny it. So we're taking people with pre-diabetes who've already had an event, MI, stroke or whatever, and we're giving them metformin to prove once and for all, does metformin have any cardiovascular benefits over there? And that's odd because this is the alternative definition of diabetes from Miles Fisher. He said diabetes is actually premature cardiovascular death. As you all know, CVD occurs about 5 to 10 years earlier. This was known from the Mr. Fit studies and all that. For the same age, smoking, blood pressure, cholesterol, everything being equal, person with diabetes gets it much earlier than the person without diabetes. Yes, there's chronic hyperglycemia, there's blindness, there's renal failure. But all these years, although diabetes is premature cardiovascular death, we adopted a glucocentric approach. Why? Your glucose goes up, you have diabetes. Bring it down. Should not everything go away? It didn't happen. It improves retinopathy for sure. Glucose control reduces albuminuria. It really has no effect on progression to end-stage kidney disease. Albuminuria going this way, that way, to me is like pre-diabetes, 110, 130, 120, coming back this way, that way. That's what I think anyway. And glucose control, as I said, per se, has no effect on CV disease. And a lot of people have forgotten the ACCORD study. The ACCORD study was stopped by the NIH 6 months early because there was more harm. People were dying more. It was CV death. Not many people realize that it was stopped because of that. Now, when we think of CVD, we think of an MI, stroke, and cardiovascular death, which is the classic MACE event. But cardiovascular disease is more than MACE. Heart failure is an important component. And this was an editorial written 10 years ago by a good one. Heart failure is present. If you go looking for it in about 20% of patients above 65. And this is data from about 10 years ago. People who have diabetes and have been admitted for heart failure, their median survival is around 4 years. It's worse than that of cancers. Of course, this is in the days before ARNIs and all that. But this was the data which existed. And it occurs early. How early? Now, this was a famous short wave study done in Italy. What they did is, they took 386 people coming into a super specialty center, diabetes of 5 years duration, A1C was really about in the 7% range. No inducible ischemia by stress testing. So they didn't do a cath or anything. Almost 70% of them have LV dysfunction. Mostly, there's systolic, diastolic, and both combined. So we do not do echoes. We do not recommend that you do echoes, but it is there. It is there, and we don't go looking for it. So what did we learn from the cardiovascular outcomes? And let's just look at SGLT2 versus GLP-1 receptor agonist. GLP-1 receptor agonist is MACE benefits. Till today, no effects on heart failure. Kidney benefits, till today, only albuminuria. The studies are going on. No effects on a hard outcome of progression to end-stage disease. SGLT2 inhibitors have got MACE benefits in people with pre-existing disease, CHF benefits, and they prevent you from going on to get kidney failure. So as I said before, I think GLP-1 act on the due to improvements in A1C, blood pressure, weight loss, anti-inflammatory, all these effects. SGLT2 is on the pump. Now everybody says the kidney is a filter. The kidney is a pump. The filter is just doing nothing, just filtering it out. The main work is done by the tubules over there. And I won't bore you with the details. Consistently, as a primary endpoint, SGLT2 inhibitors have shown effects on heart failure across the spectrum. FREF, I don't know if MREF is moderately reduced or mid-range. So if I read different literature, and of course the cardiologist over here can correct me which is the right term, but I don't think anybody knows. And HFpEF. In outpatients, in acute hospitalized patients, in patients with and without diabetes. This is what set me thinking really. But more importantly, I don't know if you realize this, benefits occur very early. How early? This is empiric, right? The first study. Time to benefit for hospitalization for heart failure, day 17. I don't think any drug so far has shown that benefit. Look at time to benefit for heart failure or CV death. Hospitalization for heart failure as a combined thing, day 27. CV death, day 59, you begin to see the p-value significant is a 72% relative risk reduction. This to me was kind of out. This was a little bit odd. Similar changes for renal, and I won't go into it. This is more a cardiology focus that. And that's why in 2016, I, along with my colleagues, wrote this review article, Can a shift in fuel energetics explain these cardiorenal outcomes? And we called it a unifying hypothesis. We said these benefits are due to a shift in myocardial and fuel metabolism away from fat and glucose, which is energy inefficient in the setting of the diabetic heart and kidney, towards a superfuel like ketones, which improve myocardial and renal work efficiency. Now, we were the first to say it is myocardial and renal. There was another, at the same time, there was another paper published by Eli Ferranini. He said it's the heart, and we said it's the heart and the kidney. And we also said the benefits occur early, and this was confirmed. Now, you all know about the DAPA heart failure study, dedicated study. Look at this curve for hospitalization for heart failure, hazard ratio 0.70. The curve is beginning to separate almost within a week. Let's look at Emperor Preserved. Same, they're about 0.67, 0.7 over there. About a week to 2 weeks. Everybody's saying these are due to diuretics. Okay, it might be, but no diuretic study has been shown. Thiazides, loop diuretics, any of those not been seen. And diuretics worsen renal function. Whereas if you looked at the renal specific outcomes in DAPA-CKD, this was a composite endpoint, of course. But hazard ratio 0.56 is as good as you can get it. Around 4 to 5 weeks, it is preventing you from going on dialysis, it's a composite endpoint, your eGFR of more than 50%. I think this is something is happening which is there. What is driving it so early? Now, this was in 2016 when I wrote it, and this was a group from Canada. They said SGLT2 inhibitions, of course, you get the metabolic benefits, glucosuria, negative calorie balance, A1C comes down, there's uricasuria. That will give you benefits on the heart and the kidney. The hemodynamic benefits in natriuresis, blood pressure is down, plasma volume is down about, tubular glomerular feedback also can occur. You get protection. But the weight loss in Emperor was only 2 to 3 kilos. That much weight loss cannot give you benefits within 3 weeks, 4 weeks. You can see there was a difference, 0.3, 0.5. Systolic in Emperor was about 3 millimeters systolic. Plasma volume is around 7% down, and most of these people are already on ACEs and ARBs. And it's possible that all these effects together can have ASCVD benefits. But in my opinion, it cannot explain the heart failure and CKD benefits which occur so early. This can only be explained by improvements in myocardial and renal tissue hypoxia, which occurs immediately. Now, this was a question I asked myself. Why should the diabetic heart become hypoxic? It is full of blood. Diabetic kidney gets 20% of the cardiac output. It's full of blood. Why is it going to get hypoxic? Well, I went and looked at myocardial and renal oxygen consumption. The resting heart consumes 8 ml per minute per 100 grams of tissue. You have about 200 some grams of it. And if you exercise, it goes up to about 70 ml per minute per 100 gram tissue. The kidney, 5 ml per minute per 100 gram of tissue. You have 2 kidneys, maybe 300, 350 grams over there. The brain, only 3 ml per minute per 100 gram of tissue, but we have 1,500 grams over there. So, and this is something I learned along the way. The largest consumer of oxygen in the human body by weight, I don't think I ever guessed it, It weighs only 2 micrograms. The retina of the eye, it consumes about 9 to 10 ml per minute. And this is something I learned. It consumes its oxygen at night, not during the day. Why? Because in most physiologic systems, a stimulus comes and you get set off whatever it does. The retina is set off by light. If that were to happen, 16 hours in the day, the retina is just bombarded. It will go nuts. So the way nature set it is, in the dark it gets activated. During the day it is there. Actually it's called the dark current. And 80% of the oxygen consumption is the rods. And the retina is very poorly vascularized. And I said, why? Because if you have blood vessels in the retina, all you will see is red. You don't. Because the retina is avascular. All its blood supply comes from the choroid. It diffuses through. See the way nature did it. The light comes in, goes to the back of the retina, strikes it, and then goes back again this way to the optic nerve. The system is so, I've written a paper on it, on a hypothesis, but just out of curiosity over there. So then I asked myself, what is oxygen doing? I always thought oxygen is used to burn the fuel in the mitochondria. I was wrong. All oxygen does is, it is a terminal electron carrier. It carries from the complex 4 to complex 5, it takes the oxygen. Remember, hydrogen keeps going on. It's a proton. Finally, half O2 plus 2H equals H2O. The H comes back inside, turns the ATP synthase. It doesn't do anything but just carries the electrons over there. And we estimate this as ATP. It's called the PO ratio. How many moles of ATP per atom of oxygen? It's like your kilometers per liter, 50. I don't think any car gives 50 kilometers per liter, maybe 20, 30. If it's a better engine, it gives you more. Glucose is the best. For each atom of oxygen, you get 2.58 moles of ATP. Palmitate C16 is 2.33. It's only 11% less. But remember, beat to beat, minute to minute. The heart beats more than 100,000, 1 lakh times a day. The heart can, now correct me if I'm wrong, the cardiologist is here. The heart can only store 5 to 6 beats as phosphocreatinine. Then it's out of luck. And the heart, which weighs 200 grams, generates anywhere from 6 to 10 kilograms of ATP. That's the amount of work the heart is doing to do it over there. So minute to minute, beat to beat, 11% deficit will add up. Beta-hydroxybutyrate is 2.50, very close to it. So in the diabetic heart, there is what is known as metabolic inflexibility. Less glucose oxidation due to insulin resistance, Randall cycle, more fat oxidation because fat is available in plenty. But fat oxidation is energy inefficient. It's energy dense because it has a less PO ratio because there is leakage of electrons. There's more myocardial hypoxia and there's more generation of ROS. In fact, fat is a dirty fuel. It's energy dense. And I wrote this in my article. I said, this is paradoxical starvation amidst plenty. You got plenty of glucose, you can't use it. You got plenty of fat, you're using it, it's not a great fuel. You're damaging the heart over there. That leads to a lot of cardiac remodeling. And actually, there was an editorial in the New England Journal just about a year ago, talk about. It says, the heart running the engine clean. You got to run that engine clean. And then you get heart failure. And Stephen Newball, who's in Oxford, he said the failing heart is an engine out of fuel. Can ketones help? And this is George Cahill. He has done all the studies on starvation. I found out that the longest a human being has been starved, of course you have to give water and electrolytes. Under supervised, it's been published in the BMJ in the 1950s, 354 days. They starved him. He lost, I think, about nearly 80 to 100 kilograms. But they gave him salt, water. They had to give him, apparently moved his bowels only once in every 3 weeks. He moved his bowels over there. But we've got plenty of energy stored in the fat over there. But anyway, George Cahill said, glucose, ketones are a super fuel. So this is my cartoon. It took me about 4 hours to draw this cartoon. So in the diabetic heart, there's more fat, less glucose, starvation amidst plenty. That leads to a less PO ratio, more ROS, less efficiency. everything damages the myocardium, more progression to heart failure, and the heart literally struggles to breathe. What happens? And maybe suppresses glucose oxidation. But if you do that, it's a better fuel, better efficiency, better contractility, less heart failure, the heart beats better. Same things happen in the kidney, and I won't bore you with it. When we wrote an article, within 1 week, this is cell metabolism. Now, if you want a great paper, you get it in Nature or Science. Next level is New England Journal of Medicine and Cell. I can never publish in Cell. So these two people, Gary Lepaschuk and Subodh Verma, they said, not so soon, in 1 week. And they said it has been hypothesized by improving myocardial energetics and empagliflozin, the fuel appetite. He cited us, Farinini and Mudaliar have said this and all. It's there. And I have to tell you that about 3-4 years ago, I met Gary Lepaschuk. He's one of the greatest cardiophysiologists. And he came up to me and he shook my hand and he said, Sundar, I'm a convert to your hypothesis. And this study, this slide should have been hidden because it comes again, but doesn't matter. This just came out early this year from this group in England. What did they find? 18 patients with type 2 diabetes, A1C 8. They underwent cardiac MRI and P31 MRS, 12 weeks of EMPA. What did they find? Empagliflozin ameliorates the cardiac energy deficient state, reverses this, everything that we said. The details will come later. This study was just published in July, a couple of weeks ago. So this is there's glimepiride as a control. You bring the glucose down. You put empagliflozin over there in people, and it was a crossover. So that is the best study you can do. What do they find? As compared with glimepiride, treatment with empagliflozin resulted in a greater reduction in myocardial glucose. I said it might go down. Significant reduction in LA diameter, LV end systolic diastolic, NT-proBNP, blood pressure, heart rate, stroke work, myocardial oxygen consumption, increase in ejection fraction, efficiency, hemoglobin compared to glimepiride. So everything which we predicted in our model, I'm not saying all studies have shown it. No. The studies are about a third. A third are positive, a third we don't know, a third say no, there's nothing over there. And this is the most, and I'm at the moment writing an article on this. Why does the hematocrit goes up? This has been seen in all studies. If you look at patients with diabetes, people without diabetes, if the hematocrit is, obviously there are male-female differences. If it is 44 in this group, it's 42 here. It's just there. Nobody knows why, how, where and when. I have my own theories why it happens. And you give an SGLT2 inhibitor, you bring that up. How does it happen? And they measured beta hydroxybutyrate over here. As you can see, it doubled, RBC count went up. Not much, 42 to 43, placebo stayed about the same. That's all well and dandy. Can this explain the cardiorenal benefits? And there is evidence now. We thought that beta hydroxybutyrate is just the fourth fuel. Carbohydrate, fat, protein. Of course, you don't want to use protein. And nature didn't put ketone body there just for the heck of it. Before, they thought it was a waste product of fat metabolism till the 1980s. And then George Cahill came and said, no, this thing is doing something. And actually, if you read his book, beta hydroxybutyrate as a fuel goes back approximately 2.4 billion years. Bacteria, single cellular, they use glucose. They use beta hydroxybutyrate. And I can give you another example. All humans come into this world ketotic. Why? In the feet, in the uterus, The fetus can only do glycolysis. There is no oxygen. It is bathed in the amniotic fluid over there. The lungs don't work. Nothing is over there. It's a parasite on the mother. All the glucose is going to the fetus. It does not even have the machinery to do fat oxidation. Little bit fat synthesis is going on. The moment the infant is born, the first 2-3 days, the mother's milk only contains globulins and all. Very little lactose there. So what's the infant going to do? It works on its stored fat, which it has a little of, and it burns. That's why in the first week of life, all neonates lose weight, and then they put it up. When they've measured it in the cord blood, they come in around 2 millimolar. Normal is 0.2. In fact, it's about 2. You say, oh, ketoacidosis, that's about 510. But why would nature, and up to about the age of, that's why kids get up every 2 hours and cry, because they're ketotic. They want glucose over there. But look at it. There's a reason nature put you into this world in a ketotic state. And it goes back to out of Africa, how we got up and got such big brains. Anyway, so we just updated a hypothesis late last year. With my colleague, I wrote this, a novel hypothesis linking it over there. Basically, we said there's now evidence that in addition to being a fuel substrate, they also have all these anti-inflammatory, antioxidative, mitochondrial, you name it, it is there. And we said we want to propose a novel hypothesis to link low-grade ketonemia to cardiorenal benefits. I spent about 6 hours drawing this diagram. So please bear with me as I show you. So the SGLT2 inhibitor blocks the transport and thus one S2 segment glucosuria. But remember, glucose is an essential nutrient. You cannot afford to lose it. If it's going out all night in your bladder, your sugar will come down to 40, 30, 20. You have to get up and eat all night. What does the body do? It reverts to a state of accelerated starvation. And that comes, of course, you have to burn fat, ketogenesis, low-grade ketonemia. Beta-hydroxybutyrate is about 70 to 80%. It depends on that NADH to NAD ratio. It's a better fuel, better efficiency, but I don't have time to do this. There is human data for anti-inflammatory effects on the NLRP3, inflammasome, antioxidative, SIRT1, HDAC. These are, you won't believe the amount of effects, histone deacetylation, erythropoietin, mTOR-C1. This is really fascinating. Myocardial target of rapamycin C1. This has been linked to longevity. When you fast, you go on cross species, starting from the the parasitic worms to non-human primates. A reduction in caloric intake by 30% increases lifespan by about 30%. The problem is we cannot do it in humans. How are you going to put them on a 30% for 50, 60, 70 years? The studies in non-human primates have been done. One was positive, one was negative, but it showed about monkeys. They've studied them up to 40 years. You restrict the calories, they live longer. And it's due to this mTOR-C1. I don't know if you know that thing. Rapamycin, we all use it, right? It's one of the first this thing. Now, it was discovered by an Indian guy called Sehgal. Where did he find it? Easter Island. You know, they go looking in the soil. And he called it rapamycin because Easter Island in the native language is Rapa Nui. So that's why he called it rapamycin. Anyway, small thing over there. This is also fascinating. Antisympathetic. Remember, blood pressure comes down with SGLT2, but heart rate does not go up. GLP-1 receptors, all of them, blood pressure comes down. Heart rate goes up 6, 8, and across mammalian physiology, any increase in heart rate is not good. Correct me if I'm wrong. Why would you unnecessarily tell the heart to beat? I mean, you can do other kinds of things with it. But anything which lowers blood pressure, the reflex is to do it. And that's because this is human data. It acts through GPR, G protein coupled receptor. Anyway, but can we link that to low-grade ketonemia? But before that, why should there be ketogenesis with SGLT2? This puzzled me. Trust me, I went to the biologists, I went to the physiologists. I said, I need to understand this. And then, this we wrote in our paper. It's a physiological adaptation. At that time, there were 2 papers in JCI and Will Cefalu. There was a Ferranini and Diffronza. He said this is a pathological adaptation. I said, it's not pathological, it's physiologic, because you're losing an essential nutrient even in the fasting state. And there is glucosuria about 100 grams in type 2 diabetes. Not many people believe this, but the studies have been done. If you don't have diabetes, your fasting glucose is 90, you spill about 50 grams. It's not a lot. And if your eGFR is down, say to maybe 30, you still got about 10 to 15 grams of glucose. It's there. It's countered by an upregulation of the SGLT1 transport. We know that. We know that this was paradoxical. Any increase in hepatic glucose production is not good. Your sugar goes up. Metformin shuts down hepatic glucose production. These drugs increase it, but it's a physiological adaptation. What's your body going to do if there's no glucose? Then this is something I also learned. There are these two tissues which can only use glucose anaerobically. The red blood cell has got no nucleus. Once the normocyte becomes a mature erythrocyte, it extrudes the nucleus. No nucleus, no platelet. How is it going to work? No mitochondria, only anaerobic. And it is fascinating. If you look at the story of the red blood cell, it doesn't need any energy, because the energy for its movement is coming from the heart. The heart just pushes it through. All it does is take the oxygen, bring back the carbon dioxide. Because if it keeps using the oxygen on the way, how much is it going to deliver? So nature said, you don't get to use it. You use it without the oxygen over there. Anyway, that's a little thing. The inner medulla of the kidney, the PO2, is insufficient to support oxidative phosphorylation. And of course, the CNS and brain can switch. It needs about a day or two. And so the liver makes ketone bodies as an alternative fuel for it. And how much is it? Approximate doubling, 0.3 to 0.6 when it has been measured. With type 2 diabetes, 0.15 to 0.3, and beta hydroxybutyrate is there. And as I said, it's similar to the accelerated state of starvation of pregnancy. And that when we submitted our paper, I have to tell you this, they were waiting for the paper. I submitted it on Friday at 2 o'clock my time, which is 5 p.m. Eastern time. Saturday, 1 o'clock. Within 24 hours, I got 6 reviews. So they were waiting for it. Those guys gave the reviews, and very good reviews. One review was 3 pages long. Excellent reviews. That's a guy who said, hey, refer to this paper of accelerated. You have put it together, but add something to it. They're good reviews, they're bad reviews. Anyway, how does low-grade hyperketonemia help myocardial metabolism? Again, so we've known for a long time. This is a study in Circulation from 2016. They said they know that there is increased ketone utilization in the severely failing heart independent of diabetes. It's about 40-45% extraction across the bed. That supports a role for them as an alternative fuel, but it's a metabolic adaptation. This study came out about 4 years ago. The Japanese did it. What did they see? 36 diabetic subjects, A1C 7.2. They compared them to non-diabetics. They matched them for blood pressure, CVD, lipids. I don't know how anybody did LVEF for 65. Now, explain that to me. I thought anything about 58, 60, but that's what it was. They said in patients with diabetes versus non-diabetes, myocardial uptake of glucose, lactate, pyruvate is decreased, as the model predicted. Ketone body increased. Fat uptake, no change in this particular thing. And they said ketone bodies are therefore utilized as an energy source, partially replacing glucose per se in the human diabetic heart. This study was published. We were all looking for this DAPA card study. 6 weeks of treatment. It was a randomized double-blind placebo control. They investigated the early effects of DAPA. 24 patients on placebo or DAPA. This was the age group, BMI, A1C, LVEF 62%. So these are all your classic HFpEF patients. A1C came down by 0.27, which you expect after 6 weeks. Weight came down by 1.2. Ketone body with placebo, I swapped it around. With placebo came down from 166 mic went up and just missed statistical significance. But this is what they said. Although effects were limited, changes in LV global strain variables, you have the radial and the longitudinal, and LV volume indicate, they said, reduced preload, They found reduced myocardial work, oxygen consumption, and they speculated it is because of reduced oxygen demand because of reduced preload. This is a study we're all looking for. I think it's well designed. It's called the Emperor Vision Trial. And Stephen Neubauer, the guy in Oxford, who said that the heart is an engine running out of fuel. So they're looking at three things. There is the NHE1 in the heart, NHE3 in the kidney. They said, is it this? We look at, now this is my good friend Gary Lopez-Chuk again. SGLT2 inhibitors have got direct effects, without a doubt. They can act on NHE3, the calcium, magnesium, dyscalmodulin pathway, mitophagy, inflammasome, direct effects, renal function improves, endothelial vascular cells, erythropoietin, improved energetic, sympathetic nervous system. All these effects of SGLT2 inhibitors decrease renal failure, heart failure, and renal failure. I want to say, causes mitophagy, positive changes, mitophagy, autophagy. In humans have shown this decrease in LRRP, inflammasome. In humans, one dose of dapagliflozin improves renal, one dose in type 1 diabetes, but it's there. And of course, increase in erythropoietin, decrease in SNS, and of course, improved energetics. Now, this is a question I asked myself recently. If beta hydroxybutyrate per se, first I said it was SGLT2 inhibitors, then I said it's the ketones they make. Now I'm saying if it is beta hydroxybutyrate, if you give it therapeutically, will that work? What is therapeutic ketosis? This is a new term in the last 2-3 years. It is serum ketones 0.5 to 2 millimolar. I'm not talking about diabetic ketoacidosis. That's usually 5 millimolar and above, usually. This was the first study published in Circulation. They took 16 non-diabetic HFrEF patients, LVF 37, one single infusion of beta hydroxybutyrate or placebo. It increased circulating beta hydroxybutyrates from 0.4 to 3.3. One infusion increased cardiac output by 2 liters per minute. LVF by 8% decreased systemic vascular resistance, significant cardiac output, even of 0.3 liters in the physiologic range over there. And importantly, it increased, in this study, increased myocardial oxygen consumption, which may not be good, but it did not affect the efficiency of the heart. First study in humans to show that it is, and they said hydroxybutyrate may be good. So, if you look at SGLT2 inhibitors, what it causes is endogenous ketosis. Your liver makes it. And you have seen it. It's got multiple effects on the heart, the kidney, all these studies have shown. DAPA, emperor heart failure, soloist and all that. We know that. Exogenous ketosis, now your body is not making it, we're giving it to you. Well, you can give it IV. I showed you that study by Nielsen et al. Improves myocardial efficiency. There are studies in humans, but giving salts orally is not good. You get a huge sodium or potassium load of the salt over there. This is the big thing. Ketone ester solution. You can give it to healthy people. It's got a whole bunch of beneficial effects. And it is accepted by the World Anti-Doping Agency. You know, when you go for the Olympics, the Commonwealth Games and all, they check to see, do you have anabolic steroids? If men, do you have testosterone? Do you have erythropoietin? All the Tour de France guys take erythropoietin over there. And they will say, oh no, this is my own erythropoietin. They have these studies where, you know, if it is produced by the body, it's different from the one they give you. Same with the testosterone. There's some tag over there that they found it. But this one is accepted by the World Doping Agency. In fact, the patent for this it's very expensive. It's about $30 a day. I bought it with my own money and I did it. It takes my ketones from 0.2 to 2 millimolar with one distance. Why? Because the patent is held by the University of Oxford and the Department of Defense of the United States Army. This is what they give the soldiers when they have to go to Iraq or whatever. It improves your endurance. And then nobody knew this. I think it was the Olympics in 2016, the swimming. The British swimmers suddenly won 5 or 6 gold medals. They said, what the heck, how did they do it? This Karen Clark is over there. Then she disclosed, yeah, we gave them ketones. It's a lie. It improves it like anything. Anyway, but this I think puts it all together. Everybody goes on a ketogenic diet, whether it is a 1 day, what we don't know is it 1 day a week, 1 week a month, 1 month a year? Different religious groups have it. Is it 1 meal a day? I don't know. Some people do alternate day feeding. I have no idea what it is. There are lots of advantages. The disadvantages, you could deplete your glycogen adherence. Cost is relatively low and you get your ketones up, but it's not easy. I've tried it. It's not easy. MCT oil, and I'll come to this later, it's got a lot of advantages. It prevents that. There are some dyslipidemia can occur, GI side effects. The cost used to be high. Now I've taken it myself. So my ketones go from 0.2, I take 2 teaspoons 3 times a day. Now it's a part of coconut oil, but coconut oil has got only 11%. This is pure C8 caprylic oil. It's available. It goes to 0.7, 0.8, which is what. So I'm trying to do a study to show that this is what is the thing over there. BHB salt, it's a problem because the sodium load, the cost is low, but if you give it IV, it's only 3 to 4 hours. The ketone ester is the gold standard, but some risk of acidosis, bitterness, GI side effects could be there, but is there. But I think you don't have to go on a low carb. Now, nobody knows what low carb is, but I've done all the calculations. The body consumption of glucose is about 250 grams a day. 125 for the brain, 125 for the red cells, the kidney, and the inner middle of the kidney and the brain to keep, after that to keep them going. The liver production of glucose is about 120 grams a day. Once you drop below 100 grams a day, you exceed the capacity of the liver to do it. And the world standard is 130 grams. Don't ask me how they got it. But if you go below 100 grams of carbohydrate a day, you go into ketogenic territory. Below 30, for sure you're there. Below 30, you might be doing grams of carbs, you're doing a disservice to yourself. Does it work? So this was a study. It's been done in heart failure patients, and these are all studies which they did. Bottom line is acute nutritional ketosis enhances the extraction in HFrEF compared to controls, and this correlates with the degree of dysfunction and remodeling. But what about healthy people? So they took healthy people, and in this study, 20 fasting healthy, they took them over, gave it to them. Those are the numbers there. Bottom line, multiple beneficial effects on myocardial function and other parameters in healthy adults. This is why all these athletes use it. It's doing something. I mean, this audience knows more about. I like this. It came in Jack a few years ago. Heart failure is very complex. I mean, as you know, there's HFpEF, for which there's all these there. There's only, till recently, only through GDMT, and also a 2B for ARBs and MRA. Right? For HFmrEF, same thing. 2B for ARBs, ARBs, and for that. HFrEF, you've got 5, class 1. And now, of course, they've added DAPA and EMPA. It's been approved by the FDA. And recently, I don't know if you know this, you should know. The FDA did not approve. They endorsed the view of sacubitril valsartan and spironolactone. And this is how they said, in people with LVF less than normal. They didn't define it. Is it 50? Is it 55? They just said, okay, MREF and LPEP. But they approved Jardiance based on the EMPREP result study to regardless. So it's across the thing over there. And I think they do cover the whole range of heart failure. But the question is, how early? This is just published in JAC, Subodh Verma. I met him actually in India. He's from India, but he's a Canadian cardiothoracic surgeon. He's the one who said, don't believe the hypothesis over there. He and I mean, we're good friends. We've spoken together and all that. So they wrote this. They said diabetes, I told you, is premature cardiovascular disease. It accelerates the transformation from preclinical to clinical. So if you look at the natural history from stage A, B, C, and T, if that is a trajectory without diabetes, that trajectory is really increased. So where do you start it? Now, as you know, you started in hospital with people. This was the Nature Medicine paper on the EMPULSE study. They said initiation of EMPA in hospitalized patients is well tolerated. and significant improvements in only 90 days. And we have to remember, in the 530 patients with acute heart failure, two-thirds had LVF less than 40, a third above 40, a third were de novo heart failure. And of course, they got all-cause mortality in 90 days, almost halved, 4 point. You all know acute heart failure is a bad disease. Any heart failure event, improved heart failure score with the Kansas City questionnaire. And it did not matter whether you had diabetes or no diabetes. Safety, of course, in this there was less AKI, and in this study there was no decay. We have to be careful, it has been caused over there. Of course, you know the sotagliflozin, which is a dual inhibitor, not approved in the United States. I do not know it. I don't think it is approved in this country as well. It's approved in Europe, but not in this country. But even in that, look at this, significant by 95 days, total CV death, hospitalization. So it's doing something. And across, whether you had HFpEF, HFrEF, whatever ref you had, it was consistent. So this, I think, is the latest thing. And I thought it was quadruple therapy. 2 weeks ago, I gave a talk to the doctors in Japan, cardiologists. So they call it the famous four. So they don't call it quadruple. They said the famous four. Acute heart failure, this is, I mean, you know better than me. And they said, don't even bother to use ACE and ARBs anymore. Continue the beta blocker, add an ARNI in hospital, and initiate a discharge and MRA. Chronic heart failure, of course, don't bother with his ACEs and ARBs. Of course, cost is a big issue. I'm not saying no. Of course, initiate same thing, ARNI, and 2 weeks start that. De novo heart failure, they said start both ARNI beta blocker, initiate in 2 to 4 weeks. You know, low dose ARNI beta blocker, titrate over time. Look for side effects. Of course, you all know hypertension, volume status, diuretic. Consider spacing medications. Discontinue therapy. This is what I've always done. CCBs, I take them off unless you're really doing something for that. Many people are on furosemide for no rhyme or reason. Some pedal edema, somebody, if I can take it, I talk to the cardiologist, I reduce it or take it off. You do expect a decline in EGFR, and of course, hyperkalemia can occur because of the mineral MRAs over them, also the ARNI to a certain extent. The problem is, this was just published in European Journal, and what they said basically is, encourage clinicians not to withhold evidence-based and guideline therapy. The heart failure population with low BP or impaired kidney function at presentation should not be undertreated. And I think in the EMPA studies, it was about 30 and 25, the EGFR over there. They reduce the risk of AKI and preserve EGFR. Of course, you have to be careful. I think we've come a long way in 100 years. This is 1916 Elliot Jocelyn, a carbohydrate-free keto diet. That's all he knew. He did 1,000 cases and he published it. 6 years later, we got insulin, one of the original vials. And then 90 years later, Nicola Diamond, she passed away. She wrote the editorial in Lancet. She said, SGLT2 inhibitors for diabetes, turning symptoms into therapy. At that time, everybody said, you're going to destroy the kidney. You're going to flush it with sugar. Turns out, that's why, it's sweet success. And this is Bruce Neal and Clara Arnott. JAMA, a novel, it's not a diabetes drug. It's a cardioprotective therapy. By the way, it improves glycemia. New England Journal of Medicine is very sedate. But this is what they said. Cardioprotection with yet another SGLT2 inhibitor, an embarrassment of riches. And Eugene Braunwald, I think, is well known to this. He's considered the father of American cardiology. Actually, he was the first chairman of medicine at the university I am at, the University of California, San Diego. Then he moved to Harvard from there. He's 93 or 94 years old. I think he came to India about 3 years old. He came and gave grand rounds. I remember at the age of 92, he stood and he gave a PowerPoint presentation. That man is incredible. He said aspirin, penicillin and statins, they all got a Nobel Prize. And he says SGLT2 inhibitors represent one of the most important pharmacological advances in cardiovascular. Clearly, I painted a very rosy picture. Are they bad? Yes, but I think the optimism is far more. And in my opinion, SGLT2 inhibitors have introduced a paradigm shift, not only in diabetes management, but also in the management of heart failure and CKD. That's why I say it's sweet success for the diabetic heart and kidney, at least partly due to the pleiotropic effects of ketones as an energy efficient fuel substrate and with all its other things on tissue hypoxia over there. Will exogenous therapeutic ketosis have similar benefits? I'm trying to find money to do the study. Nobody will give me the money. Maybe you guys can do it over here. Anyway, I'm reminded of this Sasini Raman, as you know, was the first non-white Asian and Indian to receive the Nobel Prize. And he said, ask the right questions and nature will open the door to her secrets. Let me share with you one episode. This is there in the Nobel archives. So when he went to Stockholm to get his Nobel Prize, you're supposed to drink champagne. Of course, he was a total vegetarian and a total teetotaler. He said, why won't you drink champagne? So this is what he said. So the Raman effect is when light moves from one medium to another, there's a diffraction. So he said, the world has seen the Raman effect in alcohol. I do not want the world to see the effect of alcohol on Raman. That's what he said. Thank you.
Thank you. I think you have understood what I was talking to you about, Dr. Mudaliar. Any quick questions to him? Yes.
Thank you so much for that detailed and insightful talk. I have a couple questions. So one, the benefits of intermittent fasting in healthy people is sort of attributed to this ketotic state. Do you think in healthy individuals without diabetes or heart failure, the effects are similar to SGLT2 inhibitors, intermittent fasting? That's one. Second, with the addition of beta hydroxybutyrate, do you think it has the potential to become sort of a famous 5 initial therapy for heart failure?
Oh, great questions. The first question is in healthy people, intermittent fasting. There's so many definitions of it, but clearly that is the endogenous ketosis. I told you across species increase, and that is, I don't have time. I may have another talk on the basic mechanisms. It works through histone deacetylators, which I did not know this. Epigenetic changes, I thought, genetic changes, the gene is the epigenetic changes can last 2 to 3 generations. And that's due to, there are many changes in the DNA. It can be histone deacetylation, histone methylation, but histone deacetylation, that is one of the things. And mTORC1 is one of the things which promote longevity. To answer your question, nobody has ever measured ketones in a systematic fashion in do it amongst yourself. In Amazon you can get, I have a key, I buy, it's about $50. The strip costs about $1, but for $1 you get a ketone strip and a glucose strip, and you can check it as many times. Abbott is actually going to come out with a continuous glucose ketone monitor, which will give us much more, like the CGM it will give us over there. So that is it. The second is, you want to make it, it's a famous 4. You have to come up with another name for famous 5. Famous is already taken. Anyway, I don't know. I have no idea. Somebody has to do the study to find out. But great questions.
Yes.
Yes. Yes. Yes. Yes. Yeah. Yeah. So the question is, there is hibernation in animals. Rishis have done it and all that. Is that related to this? Now, this is just recently what I found out is hibernation takes place in the cold. There is another condition which takes place in warm called torpor. And there is another one called, just last week, this Japanese guy told me it's estivism. So there are different levels at which you reduce your metabolism. There are certain things is there. And it turns out that the brown bear which sits over there does not become ketotic. It hibernates. The turtles and all go into hibernation for 6 to 9 months. I don't know. Nobody has ever studied it in a systematic fashion, but it may be, absolutely. It's going to work because ketones are there's a reason nature sent you into this world ketotic. I think, I could be wrong.
Thank you, sir, for the insightful talk. what I would like to ask you is that do you think measuring ketones would be helpful in deciding the therapeutic benefits of SGLT2 inhibitors? Because the benefits may vary in different individuals. Would that be helpful, and would that be helpful in sort of altering the doses also? Because right now we use only a standard dose of SGLT2 inhibitors.
Yeah, that's a great question. The problem is that most people have only measured fasting ketones. As you know, after a meal, insulin goes up and it shuts down ketogenesis. But even there's some people have done 24-hour meal studies. There's a slight, there is less suppression of the ketogenesis when they're on board. But I do not believe that it will, because it's very variable. Most people 0.2, 0.1, that's what you see. So 0.2 to 0.4 or 0.3 to 0.6, it depends on your diet. It depends on your diet. In fact, I've got another slide over there which shows you the reason ketogenesis takes place. Let me see if I have the slide. If there's time, I think I put it in. No. How do I link this to that? There you go. Oh, I got this. Okay, so this is the famous citric acid cycle, or the Krebs cycle, as you can see over there. So acetyl-CoA, it's a 2-carbon moiety which goes inside, comes either from glucose pyruvate. Now remember, glucose is a 6-carbon. It is split into 2 pyruvates. That's why you get 2 of it over there. And then when it enters the pyruvate dehydrogenase, decarbox takes off 1, so it becomes 2-carbon. FFA after beta oxidation can give you that. It has to combine with 4-carbon oxaloacetate. Citrate synthase, it becomes citrate, and then of course it goes around in the whole cycle over there. This is an anaplerotic cycle because each cycle regenerates a 4-carbon molecule. 2 carbons are taken out over there. Now, in the setting of ongoing loss of glucose, even in the fasting state, remember hepatic glucose production comes up, and most of the hepatic glucose production, about 90 grams, is gluconeogenesis. Oxaloacetate goes out through the phosphoenol pyruvate. It Pepsi K, it takes the thing back to gluconeogenesis. At this time, acetyl-CoA, there is an excess of free fatty acids, because once glucose goes down, insulin goes down. When insulin goes down, lipolysis is set off. There is more acetyl, so more acetyl-CoA comes in, but does not find a partner in oxaloacetate because oxaloacetate is diverted out. So then the excess acetoacetate and beta hydroxybutyrate is, because acetyl-CoA becomes acetoacetate and then beta hydroxybutyrate. It's exported out to all. The heart loves it, the kidney loves it, the brain after a period of time loves it, and all of it over there. The liver continues to use free fatty acids because the liver can make it. It cannot use the ketone. But that's to avoid futile cycling over there. So that's it. And this is, I told you, what happens over there.
Yeah, you had a question.
Wonderful. Thank you for that wonderful talk, sir. Actually, my comment is regarding asthma, actually. So we have seen in some of the patients who were referred for biological, patients with refractory asthma, when we ask them to reduce the caloric intake and then lose weight, actually, their asthma control gets better, actually.
Really?
So probably the inflammation, as you said, is getting better when there is a caloric restriction. So in all the studies which you have showed us, actually, is there any data on subset of patients with asthma where the control got better or something like that, lung function or something?
Nobody even measures ketones. I wrote to Sangeeta Kashyap. She's at the Cleveland Clinic. She did the Stampede study with all this gastric bypass. Nobody has the data. Nobody measures it. So I have no idea. You could do the study. That's great. Somebody has to do the study to show that it works. We're doing a study now. We got a grant. We're taking people with type 2 diabetes, except they should not be on insulin sulfonylureas, and we are randomizing them to time restricted eating. The best is if you can do it 8 hours eating, 16 hours off. And the later in the day you start it, the better it is. So if you start eating at 10, eat whatever you want. There is no caloric restriction. So 10 to 6, after 6 except for water, don't have anything. And they've got great apps and everything over there. And it's a 3-month study. We've got the ketones, we're measuring all that. And they could be on an SGLT2 inhibitor. We've got some guidance, but we want to find out. It's difficult to do the studies, especially nutrition studies, incredibly difficult to do. But you should do it, please.
Dr. Mudaliar, it was a fantastic talk. And I was at Brigham and Women's Hospital working in Brownwell Center for quite some time on cardiovascular research and diabetes, along with Scott Solomon and Mark Lefebvre. And some of the findings we saw in the GFR stage 2 or 1 could not be replicated in lower GFRs. If the GFR is 3 or 4, the same findings could not be replicated. With the use of statins or ketosis, or all this becomes totally difficult to handle. So we also face certain cases where use of SGLT2 inhibitors in patients with GFR less than 3 or 4. It's the worst GFR had worsened the underlying kidney disease.
Now, did you mean stage 3, stage 4?
Stage 3, 4 or worse. So it's towards stage 3, 4 and 5.
Okay, yeah, because each of 3 or 4, they are on dialysis over there. That is not the experience in the Credence study, the DAPA CKD study, and the EMPA kidney study and all that. They have taken people, I think 20 or 25.
That's correct, yes.
And they have seen, they do a post hoc interaction studies. It does not matter whether it's above 60, 90. In fact, the best data is in between 36. If it's too high, obviously, those you don't. Maybe there's not that much damage. You have to wait much longer. But once you're down over there, this is to prevent you from getting there. See, it's like it's burnt out. Now, there's really nothing more you can do. But even if you have an EGFR of 30 and your blood sugar is 100, you're spilling about 10 to 15. Now, you might say, I don't think that's any, we don't know. We don't know anything about that. Now, the other thing which puzzled me was, in the DAPA CKD and also in the EMPA kidney study, 16% of the people had IgA nephropathy. It's got nothing to do with diabetes. It's got nothing to do without diabetes. They excluded people with adult polycystic kidney disease. They took in people with chronic glomerular nephritis. All of them worked. And I have a different talk for the kidney people. There is data that the NLRP3 inflammasome plays a major role in the development of IgA nephropathy. They use steroids. It's an inflammatory condition. And there is data in humans. I have that slide is a renal thing. It acts on NLRP3 inflammasome and on the mTORC1 pathway in people with IgA nephropathy, chronic glomerular nephritis. And the good thing which DAPA CKD opened our eyes to is that they say don't use the word diabetic nephropathy. Use the word diabetic kidney disease, because diabetic nephropathy goes back to the 1930s or 40s. They found the Kimmel-Wilson, yeah.
Kimmel-Wilson,
yeah, the focal and segmental glomerular. So they did biopsies. They had out of the many thousand, they had about 800 people had biopsies. And they found roughly the cause of renal failure in the biopsy was a third. A third had diabetic nephropathy, a third had hypertensive nephropathy, and a third had a mix of everything. So all the people we thought had diabetes, they had hypertensive nephropathy, which causes a particular type. So we don't know.
So my next question was obviously regarding this IgA nephropathy. We see a very high burden of IgA nephropathy in this hospital because of underlying the liver disease patients here. It's being one of the centers for excellence for liver disease in India. Do you have any recommendations for this SGLT2 in patients with underlying liver disease? Because I need to use them for my glomerular disease and the liver disease. Any issues or concerns that you might have?
Okay, there is. We've published one paper with canagliflozin, the Mohammed Kuchai, I think, from Delhi, Fortis. He's published with empagliflozin. Others have published, and we did the MRI PDFF thing, and we showed a reduction in liver fat. Now, how that waiting to happen?
Thanks for your answers.
Okay. Sure.
I think you can just speak.
Probably not make you lose weight. You get modest weight, but you get a lot of metabolic. That is what I have read the literature, and modest. Now you could argue, but that's true. What's that? Yeah. You should publish it. You should. But I see your point. I would do the same. But to your point, that your point is well taken, but I would submit that it is the hypocaloric nature of the diet. It's got nothing to do with carbohydrates. That's my thing. You put anybody on a 1200 calorie diet, whether you could put all of it of fat and no carbohydrate, you could put all of it as it's the hypocaloric thing versus the low carbohydrate, which might be. I don't know. The problem is nobody has measured ketones on a systematic. But that I find a little odd, that the LDL came from 140 to 30. No, I'm sure. Human beings are very strange animals.
And the first lab also might have been wrong.
Who knows?
Because
But
it's
the big,
no, I'm just saying in lighter vein because such things are not possible and have never been described in literature by either the direct study or there is a Chinese study by Chinese authors in NAGM which says that no matter what you do, whether you do intermittent fasting or you do a calorie restriction, it is calorie restriction that works because they've done it very elegantly. No changes in BMI, fasting plasma glucose, triglycerides, HOMA, IR. So now what people believe is that you eat less, you live longer, but what do you live longer for is anybody's guess.
no. The other question is, how low can you go on the LDL? Nobody knows that. I mean, I had a great mentor for, in your opinion, what is the lowest LDL you want for yourself?
So when the newborns are, as you're talking about ketones in the newborns, so they're close to 10 to 20s in the newborns. Up to that, I don't think anything would happen because further that it grows. I don't think there is any role of per se LDL in any of these fats in the bodybuilding per se. But I think we're measuring something which may not be directly related to atherosclerosis, and we are taking that as a surrogate, like a glucose, what we are doing all the way. So I have my own reservations on the
Sure.
LDL.
I mean, it's but Dan Steinberg, he unfortunately at the age of 92, he passed away. He taught me a lot about lipids. He had a family in San Diego. The average LDL was 10, 8 to 10. And now we learned in neurology, Basson, Crohn's disease, A beta lipoproteinemia, they got nothing. Literally, they died of old age. The funny thing is that in these populations, they don't get cancer, they don't get inflammation, they don't get, I don't know what it is, but they did. And exactly what you said, the cord blood in newborn infants is about 30 to 40. And as soon as the newborn drinks the mother's milk, which is an animal product, they're animals, it goes up to 60, 70 in childhood, about 100, 110. And cholesterol absorption is very tightly controlled in the gut. You know, you have the name and pick like that, which the one which ezetimibe brought. The maximum benefit of lowering off your dietary fat and lipids is about 20%. Correct me if I'm wrong. And if you do it by diet, your HDL comes down. It does not go up. That's been shown. Now, at least in the short term. So that is something. The other problem is it is quality and quantity, because the ApoA1 Milano, these people who live there, their HDL is 10. They don't get heart disease. In fact, it causes regressions. And there's now a ApoA1 mimetic, which is an oral molecule. The studies have already been done with the IV, but who's going to go for PCSK9? The post hoc analysis, individual patient data, people are coming down into the single digits. We don't find any evidence of, you're getting dementia, you're getting this, you're getting that. But I think what he told me was, I still remember it. He said, Sundar, think of it this way, but this is 30 years ago. He said, LDL is the garbage. Garbage means it is essential. You cannot make any hormone without it. HDL is the garbage truck. You have more garbage, you need more garbage truck. So he says keep it at least 1:1, because epidemiological, the best predictor of cardiovascular and all-cause mortality is total cholesterol upon HDL, the good versus the bad, as it were, over there. But if you can keep it on a 1:1, he said that probably would do it. I don't know. I had some great teachers. I was very fortunate to learn from them. And he also told me LDL is not harmful to the vessel wall. It has to be oxidated. Oxidized LDL is the problem. What we're now looking for, I think cardiologists know it, we're looking for that unstable plaque. Calcium is good. It's calcified. It's, unless it ruptures. But the one which ruptures is the unstable plaque. And they're looking at some isotope which can go and find your, I think Eugene Braunwald said it many years ago, about 70-80% of MI is from a 30% occluded. It's not your stable plaque. You get all your this thing. Collaterals. You good? All right.
I think in the interest of time now we have to remember some more Hindi song that Jadugar Saiya Chhod Mere Bhaiya Ho Gayi Aadhi Raat Ab Ghar Jaane Do. So we have to call it a day. We cannot, unfortunately, however much we might want it.
Hindi nahi malum.
It's about a beloved telling her beloved that let me go home now because people will ask me questions. So I think it was a very nice presentation, and then as you said rightly, there are many things that we learn, and when we learn something, we learn something more, and then we know finally as to how little do we know. So with that, we thank you very much for your talk, and maybe hand over to Dr. Narasimhan and maybe Dr. Sai for one or two words.
Thank you, Sundar, for that. Coming over all the way from Chennai and taking a detour and day off from his vacation. Thank you very much for visiting us and sharing your wisdom. I'd like to thank both Dr. Rakesh Sahai as well as Dr. Bipin Sethi for taking some time off in the middle of a working day and coming and chairing the session. And again, thank all the staff and colleagues who have attended this meeting, especially my colleagues who helped to coordinate a lot of these things over the last 1 week, and the audiovisual Robin especially. Thank you very much for everyone. Please join us for a cup of tea outside. Thank you.